Nick, sir.
Mm.
So, the anatomy, the paravertebral space is within the extrapleural space. It extends from the thoracic level 1 to 12, T1 to T12. It is a wedge-shaped potential compartment bordering the vertebral bodies bilaterally. Boundaries of the paravertebral space. Anterolateral is the parietal pleura. The posterior is the superior costotransverse ligament. Medially, the vertebra, intervertebral disc, and the intervertebral foramen. Superiorly is the inferior aspect of the head of the rib, and superiorly is the inferior aspect of the head of the rib. Inferiorly, superior aspect of the head of the rib. The paravertebral space itself has the endothoracic fascia that further divides it into an anterior and posterior compartment. Um, I'll my next sub question is explain the technique of paravertebral space, sir.
Mm.
So first is key landmarks for identifying the paravertebral space. Most prominent spinous process will be the C7. The spine of the scapula it corresponds to T3 and lower tip of the scapula corresponds to T7. Um, Position of the patient is usually in sitting position, while in general anesthesia, the patient can be in lateral position, but which might be difficult. Uh, Preparation includes a 10 to 12 hertz linear or a curvilinear transducer, 18 gauge echogenic Tuhi needle, and a 10 ml syringe, and high volume of local anesthetics of about 20 ml. In ultrasound technique, there are three techniques, that is longitudinal oblique in plane technique, longitudinal oblique out of plane technique, and transverse in plane technique. In longitudinal oblique incline technique, um, we have to place the ultrasound probe in caudocranial orientation about 5 centimeter from the midline where the level is to be achieved, where the anesthesia level or analgesia level is to be achieved. At this point, we'll identify only the ribs on sonography. The ribs on sonography are usually seen as hyperechoic convex structure. Next, identify the pleura deep to the rib. Deep to the pleura, the pulmonary tissue is not usually seen due to air content. Um, Next, uh, we have to move the probe medially and look for transition of the rib to transverse process. The transverse process is usually seen as a square wave pattern, uh, as a hyperechoic line. So that is how we'll differentiate between the rib and the transverse process in ultrasound. Um, After moving medially, after seeing the transverse process, at this point, there are two alternatives. We have to slide the transducer cranially such that the targeted paravertebral space lies towards one side of the ultrasound screen. So we have to adjust the position in such that we have to identify both the rib and the transverse process in the screen. Uh, the advantage of this technique is that by stepping out the lower edge of the transducer, an oblique cut is made and results in both a transverse process and a rib being in the same sonographic image. So when the image is obtained with the transverse process superiorly and the rib inferiorly, allows a more superficial needle trajectory to reach the paravertebral space. That is, the depth of the needle to be inserted will be a little less. So this allows improved needle visibility while maintaining a more position. So once the costotransverse ligament is reached, we will feel a pop-up or crunch may be felt. The needle tip should lie in the thoracic paravertebral space. Then we have to confirm it by negative vessel or lung tissue breach via aspiration, then proceed with local anesthetic delivery slowly. Um, uh, When we are injecting the drug, it will be seen to push the highly echogenic pleura downwards. It should go away from the needle. So this confirms your local anesthetic injection in the correct place. This is it, sir. The
Okay.
paravertebral.
So your paravertebral space is only in the thoracic area, not in the lumbar area.
Oh no, sir. Lumbar area also can be done, sir.
There. So it has extends from the cervical to the caudal area. Okay, because paravertebral, as wherever the vertebra is there, there is a adjacent area called paravertebral area. But in
Yes, sir.
practice, majority of the time we use only thoracic paravertebral blocks for many surgeries. But you can do a lumbar paravertebral block also for lower limb procedures and other sympathectomies and other some procedures which are done for the lower limb. Okay, so
Okay, sir.
anatomically, when the anatomy of paravertebral space is asked, you must first describe there is a thoracic paravertebral space and a lumbar paravertebral space, which are commonly employed for anesthesia purposes. And there is a slight difference in the boundaries of these two. As you said, even though the medial side, it is a wedge space, wedge-shaped space. Okay, the description of this space is given in the book as a wedge shape, which is more or less like a triangular space with a
Yes,
base
sir.
and the side and the apex. Okay, the base is always facing the vertebral bodies and intervertebral foramina, and the superior, inferior, and the apical areas. In the thoracic paravertebral space, the apex continues with the intercostal space. Whereas in the lumbar areas, because there is no rib and there is no intercostal space, it will stop with the psoas muscle. Okay, so that
Okay, sir.
anatomy is also very important. And
Okay, sir.
the because they are enclosing the vertebral bodies and the intervertebral foramina, the local anesthetic that you inject blocks the spinal nerve as soon as it comes out of the intervertebral foramina, and also the drug can seep through the intervertebral foramina into the epidural space. Okay? And that
Yes,
is
sir.
why this block has become very popular, because even if you inject in one area, it can ascend cranially, descend caudally, and then medially it can go through the intervertebral foramina into the vertebral space and block. That is why it has become very popular, especially for breast and anterior chest wall surgeries, which are
Yes,
all
sir.
done with the block alone without even sedation or GA. Okay, so it
Yes,
is
sir.
important for this procedure. So you have
Yes,
to
sir.
describe that also. And if you choose the ultrasound guided technique, you have to write a lot of things like what you are describing. Instead
Yes,
of
sir.
that, if you choose a landmark based technique, you can finish the answer easily, because the question says choose one technique of blocking this. So if you choose a landmark-based technique, all you have to do is, I will go hit the transverse process, withdraw, and then go a little superiorly, pierce the osteotransverse ligament and get the feel of loss of resistance, and then inject the drug or put a catheter there and continue with that. Okay, so that way you will save a lot of time. You will not be penalized, because you are at
Yes.
full liberty to choose any technique that is easier to write in the exam, rather than it's taking too much time to describe about the ultrasound probe size, the mode of holding it. Then, of course, nowadays you are all getting used to using ultrasound for everything, and that only will come to your mind because of your practical experience. But for saving time in the examination, it is easier if you choose the landmark-based technique and do that. Okay, so you
Yes,
just
sir.
see the presentation on that.